So this is kind of a bullet point presentation. It's an update for the current year on what we've done in Hull, Washington. So it's a very quick trip through our history, and I'm going to try to focus on what we've been doing most recently, so that Q&A can be current. So we are a nonprofit grassroots organization that has been working to bring universal health care to the state of Washington for about 3 years now. Just a little bit about me. I am a member of the board for Hull, Washington, and a member of the initiative writing team. And I think my mini bio was in the invitation. I am a nurse attorney. My practice area is regulatory law. So I'm actually one of those people that reads legislation and regulations, you know, just all the time, which is very boring, but comes in handy. So just a really brief history. In the summer of 2018, we did a ballot initiative here in Washington, I-1600. Was Initiative to the People. We had drafted that initiative based on 2 universal health care coverage bills that were actually sitting in the state legislature. The problem with both of them was that neither one of them had a funding package. We thought that was probably the kiss of death to not have a funding package. So we did include a full funding package and program. Our fiscal provisions for the funding were based on a Washington-specific study and analysis by Gerald Friedman. Dr. Friedman is a healthcare economist from University of Massachusetts at Amherst. He's very prominent, has also done a lot of national review of healthcare economics, and has reviewed, for example, all of Bernie Sanders' bills that have been sponsored over the years for universal healthcare. So I-1600, we did not have paid signature gatherers, which is kind of mentioning the kiss of death again. It's kind of a kiss of death for an initiative in Washington if you don't have paid signature gatherers. We did pretty well for not having paid signature gatherers because we gathered over 100,000 signatures. After that campaign, we took the text of I-1600, thanks to some help from our state senator, Marilyn Chase. We were able to connect with the Washington Employment Security Department and Department of Revenue. They looked at our text and worked with us to help us revise our text in response to feedback that we got about the initiative, and also their own feedback about what would be best in terms of setting up the funding program in a way that those state agencies could more seamlessly pick up the collection of the funding. So our plan, after we met with them, was to revise the text yet again and try to find a sponsor to bring it into the legislative session. We did find 3 state Senate sponsors who were willing to do that. And so in the 2019 session, we had Senate Bill 5222 that was sponsored by Senator Hasegawa. Senator Chase would have sponsored it, but she was outgoing following the election in November 2018. So what did we do to change the text of our initial initiative? We tweaked it a little bit, again, after we met with Employment Security and the Department of Revenue to make sure that the collections fell more within existing state structures. So the percentage for the employer contribution did not change, 8.5%. These figures all came from Dr. Friedman's calculations. In terms of, he calculated what it would take to pay for a system that was much more efficient, and calculated that the state of Washington could save, the state of Washington, so the residents of the state of Washington could save $9 million a year over the inefficient system we have now. So our employer contribution stayed at 8.5%, was still payroll based, and Employment Security would collect that. The 2.5% employee assessment also was still income-based, and Employment Security would collect that as well. The 2.5% sole proprietor assessment, the Department of Revenue would collect and structure that as an excise tax. Unfortunately, Senate Bill 5222 went to die in the Healthcare Committee. The chair is a Democrat, but nonetheless, it just did not move. It got no hearing, there was no testimony, and there obviously was no floor vote on 5222. In the spring of 2019, after the session ended, we went ahead and we took the text of 5222 and we filed it as another initiative to the people. We were not planning to collect signatures. We wanted to poll and get feedback. That was very, very helpful. We challenged the ballot summary at a hearing in Olympia, partially in order to learn what we needed to change so we would get a better ballot summary. We also, through the polling, no surprise to us, confirmed that we needed to clarify the language in our text about federal waivers and ERISA, because there was a lot of confusion about how our trust would operate in both of those arenas. So we did revise the text of 5222 in preparation for our 2020 plan. We clarified the language around what waivers are in terms of seeking access to federal funds for Medicare, Medicaid, TRICARE, Indian Health Services, etc. Waivers are actually not waivers because there's been nothing like this. So they're not what you would think of as a waiver. Under the present system, they are basically demonstration projects. It's a way to get the money into the state fund. We don't need access to the federal funds in order to implement the trust. We can work around that and still cover those folks. It just has, a few more hoops to jump through. It would obviously be easier if we could get the federal funds directly into the trust. The bill that was introduced at the federal level in Congress in November, Ro Khanna's bill, would simplify this even further by actually creating real waivers to get those funds into states that are setting up universal healthcare programs. ERISA, do you have 6 hours and a lot of coffee? ERISA is very confusing, but basically this is the like 250 million mile view. ERISA is a federal law that sets standards for private employer retirement plans and health plans. Health plans have, for this purpose, have turned into the tail that wags the dog. The whole Washington program meets all ERISA standards. That's not a problem. The problem with ERISA is that it has a preemption clause. So basically, the preemption clause means states, you can't legislate in this area. We don't care whether you're going to legislate to ERISA standards. You just can't do it. If it's in conflict with ERISA, which has been interpreted to mean it's more than just do you not meet the standards. So we looked at a lot of ERISA cases. There was a nice case out of the Ninth Circuit in the past couple of years called Golden Gate Restaurant Association versus San Francisco. And the Ninth Circuit found that their city-based required healthcare plan was not in violation of the ERISA preemption clause. So we looked at the language that the court liked, and we plugged as much of that as we could into our new language. So the adjustments that we've made are that the trust can provide full or supplemental coverage at the employer's election. Employer contribution is required. However, the employer has to have the ability to opt to continue to operate plans outside the trust. They'll still get their contribution credit. So we think that will pass ERISA muster. Again, Ro Khanna's bill would provide that waiver and we wouldn't have to worry about it at all. So what happened in 2020, in the beginning of the year, which feels like a million years ago, 5222 in Washington, we have a biennium session for our state legislature. So any bill that was in the first year of the biennium automatically comes back for the second year. 5222 was still alive. It still did not get out of committee. So our initial plan was to once again take our revised text, this time to file it as an initiative to the legislature because it would give us more time to gather signatures. But with COVID-19, it would be impossible to gather signatures because the initiative language in the state constitution for Washington requires those to be hand gathered signatures. So there are a couple of organizations that are challenging that in the Washington court system to see if they can get a court decision that says it's okay to use electronic signatures. But we thought we'd wait and let them do that because they were better positioned. So we have a new plan for 2021. Hopefully, we will be in a position to be able to gather signatures by March of 2021. So our plan is to file an initiative to the legislature in March. The deadline for signatures would be December 31st in order to get enough signatures to qualify after the signature verifications are done. Our goal is to collect 300,000 signatures. What happens then, if we get enough signatures, is that the legislature has basically 2.5 options. They can pass it as is, or they can send it to the ballot. That would be in the November 2022 general election. The added option that the legislature has is to place a competing initiative on the ballot. We also, in a kind of a belt and suspenders approach, are looking for sponsors in both of our chambers of our state legislature, the House and the Senate, to introduce our new text as a bill for the 2021 state legislative session. So what can you do to help? This is, obviously aimed primarily at folks in Washington. To join our volunteers, we've got a new letter that we're working on that folks can just send to their state representatives, asking them to sponsor our bills in the 2021 session. Pledge to collect signatures, donate, help us find larger funders, because petition printing costs are one of the things that are substantial, as well as trying to battle opposition ads if we do make the ballot. So again, let your state, then this is again focused on Washington residents, let your state reps know that you support and demand universal coverage. The public option that got passed last year in Washington is the very smallest of Band-Aids. Personal stories are more powerful. So, and then support the federal bills as well. We support all three of these bills. So that's the end of the talking head portion. I can stop my share, and then should we just go to questions?
So Maine we are likewise trying to construct a legislative proposal that likewise historically got stuck or died in committee here. But what I wanted to ask isn't just about your process, but about some content, and you'll forgive me for not knowing the details of the Washington 5222 proposal. So my first question is, since we agree that a firm fiscal underpinning sort of is critical to answer the questions that inevitably will come up, were the fiscals that Friedman modeled based on the states receiving every and all federal money, which we'll call waivers for the sake of it, and if so, what was the percentage proposed or likely savings in that model? And if not, meaning if those monies weren't available, even though technically the trust could be established in Washington, would that alter the funding mechanism that you've got 8.5, 2.5, 2.5? That's first question.
Okay, so he, yes and no. Yeah, he did his calculations, looking at, so he did projections of what, he looked at what the healthcare costs in the state were at the, for the years that he was, and now of course his study is about 3 years old. But we have no reason to think that it's changed significantly. If anything, costs have gone up. So basically what he did was he took a pie and he said, this is what healthcare is costing in Washington state. How much are residents paying in any shape or form? So he did, of course, include, Medicare premiums in that for the portion of our residents that are covered by Medicare, et cetera, et cetera. He kind of mixed up everything that everybody was throwing into the pot. And then he crunched numbers based on, there were a couple of major factors that he looked at for the savings. One was economies of scale, expanding the risk pool, and administrative efficiencies, and then found that those alone were going to be responsible for the savings that he calculated. So what he did was, so he came up with an amount that we needed to have in the trust. And there are various in the bill. It's 63 pages, so it's not a quick read. So there are various trips that it can take through other pathways to get the equivalent of those federal funds into the trust, even if they're not coming from the trust through a demonstration project, if that makes any sense.
It makes sense. The question is whether or not it makes it less politically feasible if the varying routes that you might have to use if 1332 waivers are not available, and if all the other money that would have come to the state in credits were not available, whether that would alter the proposal internal to Washington state for contributions in lieu of health insurance premiums, would make it less enticing, say to employers, for example. And I don't know the answer, of course.
So a couple things. One is that, Washington doesn't have any 1332 waivers. And in fact, under Ro Khanna's bill, you can't ask for a universal health care waiver if you have a 1332 waiver in place.
Right.
So we kind of went, we're glad we don't have one because this would be better. Because really, this is going to replace anything that looks and quacks like the marketplace. And in fact, our bill has a trigger for when the marketplace plans would go away. And there are two pieces of the trust. There's the reserve and the operating portions of the trust. And this was where Dr. Friedman did his work, calculating where that tipping point was. So that's number one. Number two is that he looked at the current status of employer provided coverage in the state, and obviously it was only about half that would. So there would be more employers who would be required to cover their employees under the trust. However, the average percent of payroll that employers were and are paying in the state is calculated to be running at between 18 and 20%, which is a far cry from 8.5%. So we thought, well, gee, that should be pretty attractive. You would hope. And the other major calculation is what's the hit on the individual. So the 2.5%. And we have no copays and no deductibles in this plan. The only copays that could possibly happen are for some prescription drugs, and that's capped at $250 annually. So, as I said earlier, it's the same money. It's just paid from a different source, and it's a much lower figure. So that's, we would still be able. So until we got a demonstration project or a Rocana bill waiver, we couldn't ask Medicare recipients to pay us. Now, of course, Medicare doesn't cover vision or dental. So we could ask them to pay us, treating it like a Medicare supplemental plan. But no, we wouldn't get their $134. If they wanted to sign up and pay the individual premium, which is the last piece of the puzzle, there's an individual premium not to exceed $200. Again, way, way less than most people are paying. If they wanted to do that, we would then reimburse them their Medicare premium. So that's kind of how he did the what to do while you're sitting around waiting for your demonstration project to be approved.
You could sign me up and keep the premium.
Seriously, right? Yeah.
When Jerry was here a couple of years ago, he said that it might be possible to fit the plan into a Medicare Advantage plan.
That's exactly what you'd have to do. Yep.
Is that still something you're thinking about?
That's what the waiver is. We would be a Medicare Advantage plan, unless we got the straight up waiver from the Rocana bill, which means we wouldn't have to mess around dressing up like the Medicare Advantage plan. We would just get the money. Now we'd have to produce reports and jump through a bunch of hoops. But in theory, it would be a lot more seamless and wouldn't be as clunky as trying to set our, but you're exactly right. That is what the demonstration project would be, a Medicare Advantage plan. Now, Medicaid's a lot more flexible in that arena. And particularly in Washington, our DSHS is pretty good about working with, trying to come up with innovative ways to serve the Medicaid population. So we don't think we'd have any problem. It's just that it would be a little time consuming.
Why do you think 5222 died in committee both times?
So as a cynic, I would say all you have to do is take a look at the donor list for the committee chair and the committee members. So not a big surprise.
Warren has his hand up. You got to unmute, Warren.
Cindy, thanks for giving this presentation. It's a great one that I've looked forward to. And thanks for putting your work on display for the rest of us to learn from and to ask a few questions. I really wonder about what employers would be likely to do. You've put some things in there for ERISA, and a lot of the money is coming from employers. And I'm worried that if they choose to stay where they are, like in self-funded programs, which I understand that they could, tell me if I'm mistaken about that. That's
right. Unless the right.
You're breaking up. Could you repeat?
Yes, they could unless we get a true ERISA waiver, which can only happen at the federal level. They could stay right where they were. Yes.
And I worry that how much of the potential savings you lose because you've still got a very two-level multi-payer system. So what you thinking about that?
That is obviously a real concern. We have made a lot of visits to, for example, we thought a good place to start would be with their employees. So we've been doing a lot of talking to the unions here, you know, it would make sense to, it seems to me that, you know, if we could get in front of employers and just show them the math, hopefully that would, you know, that would be persuasive, because they would get the same or better coverage for their employees at a much lower cost, both to them and to their employees. So it just makes us scratch our heads.
That may be true, but I think, you know, speaking as an employer, there's a lot of concern or a lot of belief that you're paying more for your health care and for the quote Cadillac systems, and you're getting better care. They're more likely to find a specialist who will serve you. So I think that, I mean, I just don't know. I think that might be a hard sell.
Yeah, you know, I've been a healthcare provider myself, although I don't work clinically anymore, for a very long time. I think most of the inequities in terms of, you know, who you can see, and historically it's been, oh, well, they won't take Medicaid. It's Medicaid usually that's the problem. They won't take Medicaid. So there your world is very restricted. One of the advantages to the trust is that there is no network. So if you want to get paid as a provider, you've got to take care of Washington residents. So there's no network. And we think that is probably the biggest leveler. And the benefits are as good as you would get in a Cadillac plan, unless the only difference would be if you had a, you know, a real Cadillac plan and the enrollees were paying less. I have some colleagues who they work for healthcare systems and they have those kind of plans. And so we have a savings calculator. So you plug in what you're paying now, and then you come up with what you would pay under the trust. And so I had some of those colleagues do those calculations, and they all said the same thing. Hey, I would pay a little bit more, but not much. And they also said, I'd be happy to pay more, because they're all healthcare providers, and they would really like to see people not have to use the emergency room as a primary care doctor, right? So, yeah.
Give a moment for,
Alan's
Can I-
got- yeah.
can I ask a question? So it sounds like a great plan. I'm down here in Vancouver. I have a question on capping costs. Who adjudicates ceiling costs for procedures and for Medicare?
So under
And
the
is that at the state level, and is that the way other governments do it, where they just publish the book and say, here's what we pay?
well, that's what CMS does, right? But France
Too. So
Canada
does
does
England.
it, for example, province by province. So the way it's set up in our bill, there would be three separate committees under the trust board.
Uh-huh.
And the trust board, so we already meet the criteria for Rokana bill waivers, because our structure would be administered by the healthcare authority, which already has significant experience in negotiating healthcare plans for state employees. So that the trust board would be advised by three committees. One would be a finance committee, one would be a provider committee, and one would be a patient committee. The trust board, the trust would have the authority to negotiate rates. And so this bargaining power also is very important, particularly with prescription drugs. So that they would have the authority to negotiate rates the same way CMS does,
Okay.
or Medicaid does.
No,
right.
that's a good.
Yeah.
Thank you.
Sherry has her hand up.
Hi, I'm from Washington State also. But I have a question, and it's probably real basic, but I want to know what happens when Biden gets elected and he promotes the Affordable Care Act. is that going to have any impact on whole Washington and what we're doing?
It shouldn't.
And-
We, because the ACA is still there. The ACA was just, it didn't go far enough.
Right.
And Washington's marketplace is still around. We don't have a 1332 waiver, so we haven't done anything fancy with it. And again, it kind of depends on whether 5010 passes at the federal level as well, and so that we could just go off on our own. But basically, this would replace our marketplace plans. Of course, until we get an ERISA waiver, some of those marketplace plans would be sticking around because employers would still have that flexibility. But yeah, I don't see that the ACA is in conflict with what we're doing. Because we're just another source of, we're kind of like a big fat marketplace plan.
Warren had his hand up.
Yes, getting back to employers, one of my concerns about having a fixed employer assessment, I like the word assessment better than tax or something, is that there are a lot of employers, and both public and private, who are paying 22 to 25%. So if you suddenly, and at the same time, there are a lot of employers who are paying 0. There are probably no employers who are paying 10.5%. So if you have a uniform tax of 10.5%, then the concern is that you've created a windfall for the wealthiest employers and employees, and you have created a hardship for employers who can't afford to pay that much. I noticed you have some hardship waivers that you have in there, and I'm concerned about how those have worked. But anyway, that's a concern. I wonder if you could address that.
So the assessments are based on the individual. So it's 2.5% of that higher paid employee's income. It's not 2.5% of their payroll across the board. Well, it is for the employer, but the 2.5% assessment is per individual. It's collected by the employer, who can opt to cover it, but they also can opt to deduct it from the employee's paycheck.
And I'm talking about the 10.5 health security assessment that goes to the employer.
It's 8.5.
Okay, I may not have the latest copy of 5222.
And that's true. That's a lot less than they're paying. And when we've talked to some union groups locally that have said, well, we spend a lot of time trying to negotiate for better healthcare plans. And yeah, that's ironically, that's true. They'll save money. So, maybe they could pay better wages with that. Yeah, I know I'm an optimist, but yeah, and also we have, because all employers would be required to cover their employees under our trust, we'd have more employers participating.
Can you address the fact that you have, I think for 6 years in the version of the bill I read, employers can apply for a hardship so they don't have to pay the assessment?
The part of that 6 years, unfortunately, is logistics in terms of ramping up, because the trust has to be funded at a certain level before it can tip into the operating mode. And so that was just kind of, and plus employment security and DOR would be ready to be up and running more quickly than ESD. ESD is still working out the kinks for the new state sick and family leave program. So basically they told us it'll take us a little longer to get going with this. And so between all of those things, we didn't really think that that timeline was going to allow employers to be claiming hardship for a protracted period of time. But that's something we can certainly look at and see when we come out of this, right? Because everybody's timelines have now been shifted. You know, now we're another year down the line. Maybe we want to change. We're actually looking at changing all of the timeframes in there because we are a year out from where we thought we would be.
Well, Thomas Stern and then Helen.
Well, two things. One, to ask Cindy and maybe compliment what Warren was asking about. At least in Maine, one other employer savings that would accrue would be the elimination of most of the workman's compensation, the medical portion of workman's compensation that in Maine employers are obliged to provide. And even to an employer that doesn't offer health insurance coverage to their employees, that would, and especially in a place like Maine where there's a lot of lumberers, carpenters, plumbers, electricians, etc., that sort of run under the radar, that would still represent a sizable savings. That's a good argument that Cindy could make to employers if it's not already, or I don't know the rules in Washington. But aside from that, I have two questions. One was what's included in the benefits package, Cindy? So one gray zone area, depending on states, is the coverage of long-term care. I don't know what's in Washington. And the second question I have is how does the state work with the VA?
The first, what's included in the package, the package is not, the benefits package is not defined in detail in the bill, because that's fodder for regulatory, for fine tuning that usually doesn't show up in statutory law. But basically the bill says it cannot go below the ACA's essential benefits package. And then the details of the package would be developed by the board with the advice of the committees. It also has to include vision and dental. There is a provision, a section of the bill that says after, and I'm blanking on how many years we've got in there. After a certain number of years, the board is supposed to make plans to fund long-term care as well. What happened in the interim is Washington has a long-term care bill. So long-term care it's got some holes, but it is a long-term care bill. So we will actually have to go back in and tweak our language so that it meshes with the new bill for long-term care coverage.
And the second part was the VA system of care?
The VA system. So that is a very interesting question, because the VA is the only one of the federally funded systems that also provides the care. We, as a practical matter, the state of Washington works extremely closely with the VA because UW-Medicine and the VA use a lot of the same providers. UW has boatloads of faculty who are providing care up to full-time at the VA. So that's a real interesting question. We did not specify in the bill because, again, we can't, right? It's kind of like ERISA. We can't say, oh, and by the way, we're going to take over the VA also. We just can't do that as much as we might like to. So that's a real interesting question. The VA, at least in Washington, it partners with state efforts a lot. So it will be really interesting to see how that to fold in.
Thank you.
I think it was Alan and then Jeannie.
Thank you. I'll be brief. what provision is there for people who are not working, people who have retired early and are not working and are not Medicare enabled? I can't think of anybody else that falls in the gap that does not have an employer or is self-employed.
Right. So this self-employed those are the folks that would pay the excise tax to DOR.
Right.
That would be a sole proprietor with no employees.
Right.
Folks who are not working, all they would have to pay is the premium. We do have a lot of folks who would not pay anything because they're below a certain income level.
Okay.
There's no charge of any kind for anybody under the age of 19. So,
Okay.
yeah, so that's what we did with that. We did a lot of federal poverty level, basically exemptions. And then there are also exemptions from the assessments.
Okay.
And so that's to cover everybody.
And
That's a better solution than other places. Thank you.
Thank you.
Jeannie Nicholson. You're up.
Thank you. In Colorado, we did have an initiative on the ballot in 2015, and it did not pass. One of the reasons we think that it did not pass was that the public did not understand the change that it would mean to them personally. And I'm wondering if in the state of Washington, you have a detailed strategic plan to make sure that the public is ready to vote for this initiative in 2021. And if you'd be willing to share that strategic plan, because I think that no matter how good the plan is, if we don't have an educated public who understand how this will benefit them personally, it's not likely to pass.
Right. Actually, we're working on that all the time. We're trying to increase our visibility. We've got, I think one of the best things we've got is the savings calculator, because an individual person can go in and see right in front of them, what do I pay now? What would I pay under the initiative? And if Jen Nye is still lurking here, I should probably just have her describe it, because she's our strategist actually for that exact thing. Are you still here, Jen? Maybe not.
I don't hear.
Hi, Cindy. Yeah, I am.
Cool.
So yeah, it's on our website. If anybody wanted to check it out, it does require you to input information like from your tax records and from your pay stubs and anything that you might pay out of pocket. But it will give you a really solid foundation on what you would be paying.
Yeah, and there's one for employers also. So employers can go and fill in a separate savings calculator, and then the individual person can fill it in. And then Jen also works on our strategic efforts to get this information out to residents of Washington so that they do understand what this means. And that, one of the common areas of confusion that always makes me scratch my head is, for some reason, people think that they're going to be paying this in addition to what they're paying now, which it's just, I don't get it. But anyway, so yeah, it's an education campaign is, we're constantly trying to improve how we can get this information out just to Washington residents. We have volunteers who have gone, traipsing all over the state to do presentations to various groups. And that's another way that we're trying to increase visibility.
Mark Kroll has his hand up.
Got to get off of mute. Hi, Cindy. A quick question. What do you tell when we present or discuss this with representatives from unions? What do we tell them to sort of to get around the idea that you're asking, that they'll come back with, which is you're asking us to essentially abandon something that we spent years bargaining for?
Yeah, I mean, that's a tough one. I guess, you know, I tend to put on my nurse hat and say, look, you want your employees to get the best health care they can get. This package will provide them with the same or better benefits as they're getting now in terms of health care. It'll be simpler for everybody. And wouldn't you rather bargain for something, not have to worry about that anymore? Your employees are your members are taken care of, and it's not tied to their job. So they
Right.
don't have to stay in a job that they don't like.
Oh, absolutely. No, I mean, I understand it. It's just that, but for some reason, there's
I know.
there's a barrier.
For
And I
sure.
mean, when I was on the job, I was a union employee, and I'd have dropped my corporate health care in a minute, but not everybody seemed to sort of understand that.
I know we have run into that. And I think you're right. They've spent so many years battling for healthcare because they had to.
They don't know what else to do.
Right. And I think there's a little element of, oh no, this is too good to be true, so we're not going there. Yeah.
I got you. Thanks.
Can I ask a question, Cindy?
Sure.
One is if it's possible to show how inadequate self-insured systems are. My understanding from David Belk, who's talked about this, is that, yeah, it looks like the premiums are lower per employee, but there's no oversight by the employer over what that secondary or third payer insurance plan does and why they would pay so much for this or that. So that's one question is there other talk about how the self-insureds are not nearly as good as they seem to be? And the other is, if this plan doesn't happen to match what people are already getting through their union, is there a possibility to grandfather in some of those benefits?
Yeah, and those are both great questions. In terms of oversight, the current system is so fragmented with so many payers in the market, and it actually drives healthcare systems crazy because they have to negotiate with all these payers, and the cost controls that are necessarily put into place because of the administrative inefficiencies end up meaning that a significant cost control is denying care. So it's just, and it doesn't matter whether you're self-insured or you've got, because even if they're self-insured, they've got a TPA. You know, they're not managing those claims by themselves.
Right.
So they've got a TPA, and because it's so splintered and fragmented, and there's only individual bargaining power over rates, unless you're talking about Medicare, right? Which we're not. That is where a lot of the inflated costs come from. I have a lot of colleagues who are still working in the healthcare system, and quite frankly, they're very concerned about, well, what happens to us if there's universal healthcare? We're going to get Medicare rates, and we can't stay open. And I keep telling them, your margins are so thin because you waste so many resources trying to keep all of these plates in the air. Your costs should go down, and you'll be able to survive better on rates that have more, you know, where you've got one body doing the collective bargaining. And that's what the basis of Jerry Friedman's whole analysis is. It's shocking to see in his report the piece of the pie that's taken up by administrative inefficiencies.
10.5%.
Yeah. And then there are all these little trailers that go along with that, like the amount of time that individual healthcare providers spend arguing with various payers about why they denied this care or that care. So how different would that care environment look if they could actually spend more of their day taking care of patients? Well, they'd see more patients, right? And so then they could bill more, and they wouldn't
But
have, yeah.
Single coding system.
Well, exactly. I mean, most of the private payers use the same codes, but they don't use them in the same way, and it's just it's mind-boggling. I mean, think of all the people, and we do have a displaced worker provision, by the way. Think of all the people who have to work on that stuff that you have to employ.
Well, the last part about grandfathering, is that something you're considering?
So employers could certainly use the trust as a supplemental plan. And that is one of the options that is in the bill. And that is an option that we've talked to the union folks that we've talked to. We've said, hey, you know, if they want to do it one step at a time, maybe they'd like to use the trust as a supplemental plan to cover whatever's not potentially in their plan. So yeah, and also the as long as the risk is around, they don't even need to be grandfathered. They can just hang out where they are. But yeah.
Thank you. I see Thomas's Stearns, and then Ronnie, sure. Maybe him first, or
Fine, either way.
go ahead, Ronnie.
So, Cindy, you're aware of what's going on in Washington, that there was a real victory to create a work group, a universal healthcare work group. And I'm wondering if that shouldn't be the conduit to make something like this happen, rather than going to initiatives or the bill that, I mean, someone asked, why wasn't the bill even heard? And I think there was all this backroom stuff going on that ended up as a real victory for healthcare progressives of creating this work group. Can you comment on how this bill, and the work group is supposed to come up with a recommendation to the legislature in 2021. So how does this bill fit into that picture?
So the work group, what we got out of the legislature was the cascade option, which is, as I mentioned, was barely a Band-Aid. And we got this work group. So we got these, so funds got allocated to do a study that's already been done by Dr. Friedman, number one. Number two, if you look at the composition of the work group, it is very industry heavy in terms of payers. We have, our organization has sought input. We have basically been denied any input. And I just, it made me shake my head. I can't imagine why we spent that much money to study the feasibility of universal health care in this state. And, you know, obviously we want to see what they've got in their report, but again, my cynical nature, I am not, given what I've seen over many years in terms of reports to the legislature that get funded this way, I am not holding my breath for much of substance. So.
Tom Stern, got his hand up.
Well, although that was a new topic, from my point of view, work groups are where another location where progressive legislation goes to die. Sorry for being so cynical, but that's been the 2-3 year quote unquote work group main experience. And it's another place for things to not move forward. It isn't that they're mutually inconsistent to proposition the movement on a bill can and should go forward, because if it gains public support, what goes on in a work group changes as well. But I don't want to say anything more about that. What I did want to say was to add another, I'm sure already used argument when talking with union membership about their uncertainties about adopting the unknown against a known package that they've received through hard work against their or with their employer. And that is to point out or to ask the question, what has happened with the actual real amount of money that you, the employee, have had to spend on healthcare over X period of time? And that's because negotiated agreements on health coverage have, at least nationwide, progressively included more and more copay and deductibles that fall directly and first on the employee.
Right.
And even in really good negotiations, it's easy for people to be blinded by forget about their actual total money laid out, including out-of-pocket expenditures. The trend in agreements between employers and employee groups has universally bumped those two features up, copays and deductibles. And you need to look at the real effect, A, the real price to you, and B, the real effect on your healthcare seeking decision making with regard to when you've got what you've got. So I don't know. I mean, if I were talking to employees or employee representatives, that would be another really important question that I would throw out to them.
Right.
The other thing I wanted to say, both to Cindy and the woman working with her with regard to strategic planning, is that in Maine, when we did through Maine Center for Economic Policy, our fiscal analysis, what we included in it were 10 very personal scenarios of what 10 different kinds of people in Maine would end up paying in a new plan compared to what they got now. And they included individuals and families. They included self-employed and employed in an organization. They included an employer, and they included 2 or 3 examples of retirees with Medicare as a big fraction of their healthcare coverage. Those are personal vignettes. Now, they're obviously, contrarians could argue that that's smoke and mirrors when you don't have really, really hard numbers. But they were very powerful in showing people who fell into, probably 90% of people fell into one of those 10 scenario categories, about what they have now and what they would have. And they included their premium expenses and their out-of-pocket expenses. It's a good advertising mechanism, is I guess what I'm saying.
Yeah, that's a great suggestion, because we do have, as Jen noted, we have the 2/7 calculators available, and so we could.
It's quicker and easier for lazy folks.
Yeah, for people who are willing to share, that would be great.
So Hank Abrams has his hand up, and then Chuck Pinocchio.
Yeah, thank you. I've been in California since 2001. Before I came here in 1994, we had a ballot initiative. And I think, Dave McClanahan and others are very familiar with the experience that California had. But ballot initiatives obviously are very complicated. And I think this gets to the point that I wanted to bring up, which is the political context for what you're trying to do in Washington. And we're trying to reboot our state-based initiatives in California. So at the moment, we don't have a bill in the legislature. We crashed and burned in 2017. And we're preparing, we're rebuilding our coalition. And we focused a lot on the political context, which is the pandemic, systemic racism, police brutality, the diversification of our voter demographics, the shifting power in our state, and basically the failure of employment employer-based health insurance. I mean, it represents a market failure. So I just wondered the extent to which these things are on your minds as you're trying to build popular support, either for successful passage of a bill in the legislature or for a ballot initiative. And the last thing I want to say is we're very much, we want to partner with you to do everything possible to get Ro Khanna's HR 5010 passed.
Yes, absolutely. Yeah, that's very much on our minds. In fact, earlier this year, we engaged in a lot of activity trying to get our state to do a special legislative session. And what we were looking for, if we could, was to get a quick version of 5222 passed so that it could be implemented, because in large part, directly because of the crisis that has probably, as a practical matter, doubled the number of uninsured people in Washington because of the job losses. And so we thought, okay, let's see if we can get a special legislative session. No, they decided not to do one. But that is certainly another, that's a drum we can beat in January, because we're still going to be reeling from the results of healthcare coverage that's linked to employment. So yeah, I totally agree.
And just, sorry, just to jump back in with one final point. We in California look to Pramila Jayapal as one of our heroes, and we're very much inspired by her, and you're lucky to have her. And so just to mention HR 6096, and I wonder the extent to which your state-based state-based focus and you're having a leader in terms of national health legislation. How do those things come together?
So we fully support obviously her efforts and Bernie's efforts in the Senate. We want to see universal health care. Whoever gets there first, if it's federal, that's good with us. But in the meantime, we're going to continue to work at the state level. Right now we're trying to get actually some time with Pramila to see how we can better coordinate. And we're also working with the folks who are on Ro Khanna's team for that. So yeah, I think it's cover as many bases as you can, which is why we're doing initiative and trying to get bills in the legislature as well.
So next is Chuck Pinocchio and then David Loud.
I'm unmuted, Mike.
Yeah, you're on. You're good now.
Terrific. And really, Hank, thanks for setting the table. I think it's a perfect pivot to discuss the elephant in the room, which is political power. No matter what path we pursue, if we don't have political power, we're not going to achieve that which we desire, which is not only universal health care, but universal health. And this is something that our movement really needs to think long and hard about strategically, and how we build alliances and how we build political power with folks who don't necessarily look like us. I mean, all the folks on the screen here are, if I'm fair here, I think everybody's above 50, white. I just want to keep this real. We need to expand our reach. And Cindy, I've been working with Sean Kavanaugh.
Yes, our new base campaign director.
Yeah. Yep. I mean, these are terrific thinkers. They're actors. They're new, relatively new, especially in the case of Sean. But look, people of color have got to be part of this movement. We've got to understand this is a justice issue first, if we're going to make progress. the difficulty, and I've been working in progressive politics for 47 years, the environmental movement, the peace movement, labor movement, and now healthcare movement. And by the way, our labor union just launched, and we are about to win our faculty union labor fight in Philadelphia. There aren't too many victories going on. Thank you, Barbara Pearson. We're battling on so many fronts. We've got to join hands. We've got to join arms with the people who are in the streets. 25 million, some Black Lives Matter unique participants have been in the streets since the spring. We've got to join forces with these people. And we have to do so in a respectful manner. So I guess what I want to ask you to just comment on here, Cindy, is what are your thoughts on how we build capacity, how we build power to succeed at any level, but in particular the approach that you're taking? What are your thoughts on how we get that done, how we are able to build a strategic vision that really wraps around all of the social determinants of health, not simply healthcare? Thank you, Cindy. And great to see you again. Thank you.
Well, it's an issue with many tentacles, for sure. Healthcare disparity goes, as you mentioned, goes well beyond the affordability of healthcare itself. It's deeply entrenched in the same systems that, have brought us to the issues that are being argued by the Black Lives Matter movement. I think you're right. I think no matter what issue you're looking at, you have to look at how it's related to all the other issues that got us to where we are. And unfortunately, as you also mentioned, it's very difficult to succeed in the current climate in this country, because it's all about money and power. And as long as it's all about money and power, if you don't have one or the other, or preferably both, your chances of being successful, it can be disillusioning and make people kind of throw up their hands. But I think our piece of this pie is just a piece of the pie. And I am personally involved at other levels, not just, our whole Washington. I actually teach a class at University of Washington about healthcare technology. And we specifically have put in a healthcare disparity panel of people of color and people who are out in the community looking at healthcare disparity, particularly related to technology. And so it's those kinds of things. You have to look around and see who's not at the table. And then you have to go out and find them, and see if you can't ask them to do the work, because that's, they're exhausted. But you have to seek their advice on what you can do from your position of privilege, to try to turn this stuff around. And one of the things that we are including in all of our information is we've got all these uninsured people in this state. And the one thing that this will do is it will cover everyone. So that's a start. Now, it won't address other healthcare disparities, but it will address that one. So I wish I had the answer.
It's not, it's sort of putting you on the spot, and I realize that, but my basic argument is that we can't succeed unless we have the support of the social justice movements that go beyond healthcare, right. And they can't succeed without our joint support. So Correct. Until we collectivize our political power, I just fundamentally have a difficult way of seeing how any of us succeed. That's the premise. And that's based actually on research. I'm going to put a link in the website for anybody interested in looking at this. It's NV database, nonviolence database. It's swarthmorecollege.edu. And really, it's a story about more than 1,000 successful campaigns over the last 100 years that tell us one fundamental story, that until we all come together, none of us will come together. We won't succeed. That's my message for tonight. And thank you so much, Cindy. I really appreciate the work you do. Thank you.
There's Sean.
David Laud has his.
Yes, thank you. And thank you, Chuck, for bringing the dimensions that you did into the conversation. I think that's absolutely critical. And in 2021, the pandemic is still going to be with us.
Right.
And we know that the public health crisis has to be solved before we can solve the economic problems or address the racial inequity problems. And so it is all tied together. And so we got to gain more power in these elections and in building our movement. I wanted to get back to a much smaller point. And Cindy, I was really surprised at how you characterized the Universal Healthcare Work Group in Washington, because I think it's much more significant than you suggested. And it isn't industry heavy. In fact, there's labor, tribes, community advocates, community healthcare providers. There's all sorts of folks in this work group. And a lot of us are working with I'm not a member. Ronnie, who asked you the question, is a member of the work group. He's a retired pharmacist. But a lot of people are having input into the work group, and I'm not sure how you tried and didn't succeed, but the door is still open there. The next meeting is September 16, and one of the things we're doing is we're really ramping up the public comment portion of the work group and its meetings. But I wanted just to end with this. Right now, the work group, first of all, the work group's mandate is to tell the state how to establish a universal healthcare system. That is the mission. That's what they're supposed to come up with. And the three options that they're considering right now are, number one, a universal public plan administered by the state, so single payer. Number two, a universal public plan administered by contractors, as with managed Medicaid now. And number three, an incremental approach to keep building on what exists. In the August 25th meeting of the work group, there seemed to be very little support for the incremental approach, and all the commentary was either on why the public plan publicly administered is the better way, and there's some support for contracting it out. But and I think, by the way, another point is that there's a lot of recognition that the federal support will be needed to make this possible, and that gets back to 50-10 and all that. But I just wanted to say that the work group, I think, is much more important potentially and significant than you allowed for, and I don't want people to think that that it's a lost cause. We're very excited about it.
Well, and that has just been my experience with the work group so far, that we haven't had a whole lot of luck. Now, I haven't been I haven't been directly involved myself in efforts because I'm the regulatory analysis person, right? So others from Whole Washington can talk about. My impression has been that they have not had any luck getting any input to the work group, but that doesn't mean that we should give up, obviously. And a lot of my cynicism comes from years of looking at work groups, not just this one, but work groups that are commissioned by the legislature. It's just kind of like, yeah.
And by the way, the pandemic and the economic crisis and the racial equity crisis, I think, is also going to strengthen the hand of all of those in the work group that want to really finish the job with a universal public plan that that is on a scale necessary for the crisis. But public comment and the way a lot of us are working with the work group is that actually Healthcare's Human Right Campaign that Whole Washington is a member of, we have a subcommittee that's working with members of the work group, and we're having regular meetings about strategy and how to push this and raise that and how to increase public comment and so on. It's not a lost cause. Let me encourage you to get more involved.
So David, or Sean,
We will do that.
Sean Kavanaugh has his hand up. You gotta unmute yourself. There you go.
Hi, this is Sean. I'm with Whole Washington. I've been listening in the entire time. I've just been driving, so couldn't comment. But I want to just jump back to something Chuck was talking about the interconnection between healthcare, Black Lives Matter. You know, it ties all together. Racism affects, Black people in this country a bunch, as everybody here knows, but, it causes us to have lower healthcare outcomes, but, among other things. But it also ties into the environment. We have all these fires going on, pollution increases the rates of asthma, and lo and behold, the drug companies raise prices of, inhalers. And so by passing, healthcare and universal healthcare in our state, in this country, causes the government a fiduciary responsibility to address issues that increase the cost of healthcare. And I think we can organize and build a coalition around those issues. And then two, I have a question for Cindy. When I talk to people about Whole Washington and how it's implemented, some think it sounds kind of like a public option where people, we implement the bill and then people then decide, do they want to jump in or not? And I was wondering if you could address that, and if yes, that people decide to opt in, how soon do we think that we could implement the bill in its entirety? And if people decide not to opt in, does it just fail?
So individual people can decide whether they want to sign up, but it's not an opt-in in that private insurers cannot operate in Washington except to cover something that's not covered in the package or under the ERISA workaround, because there's nothing we can do with ERISA unless we get something at the federal level. So it really isn't an opt-in, if that makes sense from that perspective. And then in terms of how quickly it would be able to be implemented, so originally it would, under Gerald Friedman's analysis, once the trust got up to 50% funded, it could launch, and that was projected to take about 2 years. Now, with the pandemic and the economic upheaval, might have to rethink those timeframes, obviously. So it would kind of depend on how quickly the trust could get up funded to 50%. And also it would speed things along if we did get the federal, real waivers through 5010, which would speed up our getting more funding into the trust. So it would basically be, the only opt-in would be employers, because we can't do anything about the ERISA preemption provision unless Ro-Khanna's bill passes. And then it's not an opt-in. If you want healthcare coverage in this state, it's the trust, except for supplemental stuff.
Mm-hmm. So prior to 50%, are people just paying into the trust, or are they getting healthcare? And after 50%, everybody else in the state is included?
The details of what is available as it ramps up would be worked out by the board with the 3 advisory committees. Because first the board has to get appointed, and then they have to, obviously they have to look at, okay, which steps mesh together in terms of how we're going to collect funding. Are we going to start doing these assessments in order to start funding the trust? And then when are we going to start basically being able to roll out care? So those details, you can't put that in statutory law. You almost can't put it in regulatory law, although we made sure to give the Department of Health, the Employment Security Department, and the Department of Revenue rulemaking authority so that those regulations could be promulgated as well.
One last question. Just one, it's a quick one. When we're funding the trust, are the employers and the employee paying the full payroll tax?
That also, with the ramping up of that and when that would start happening would depend in part on whether Employment Security and when Employment Security and DOR would be ramped up. And so they, in theory, they would be working with the trust board and the 3 advisory committees to figure out, okay, when do we start collecting this?
Well, in fairness to Cindy, we don't know how long you allowed for this tonight. I do see at least one more question. Are you available for another question or two, Cindy?
Yeah. I have to get off before too long, but another couple questions is fine.
Okay, I see Warren George's hand up. You have to unmute, Warren. There.
And this is kind of a policy question, but since you're a regulatory person, I may not get another question to ask. Washington seems to be doing something a little bit unusual to me in the way that it's handling self-employed people. And particularly, I mean, you say in some paragraphs of the bill that you're working under Section 1402 of the Federal Revenue Code. But yet you seem to be levying the tax to sole proprietorships. And those two are kind of different. Not all self-employment income comes from sole proprietorships. So I wonder if you could address that in a minute or less, and if it takes longer, maybe you could send me an email offline.
I can definitely send you an email, but if I understand your question, the only one that's structured as an excise tax that collected by DOR is for sole proprietors with no employees. Everybody else is funded through the Employment Security Department as the employer payroll piece, and then the 2.5% assessment on the individual employee comes through that pathway. So it's not all going through DOR.
What about partnerships and LLCs?
It wouldn't matter if they were employers that met the definition of employer, they would be under employment security.
But if they have no employees?
Yeah, right. They would also be doing the excise tax through DOR.
Okay.
Thomas Stern, last question.
Oh, last question. Well, I don't want to sound, I don't want to sound like a naysayer, Cindy, but the devil really, both politically and fiscally, it ends up being in the details. So some of the hints that Sean has thrown you with regard to what goes on in the ramp up period and the ramp up for funding and for coverage ends up becoming both fiscally important, because you know as well as I that the quicker the trust gets funded, the better,
right,
for 100 different reasons. And the slower it takes, the more political opposition builds. The problem of people saying, I'm throwing this money into what for when, becomes an issue in the second or third session of the legislature once the bill gets passed. And And so that's a real challenge. And it's a challenge, especially to the not only to the ramp up, but to the fiscal underpinning of the bill. Because if the bill's going, if the system's going to lose money because of self-employed folks not buying in, or because of the vagaries of contributions, it's a non-starter. We all know how much money is savable, potentially savable, but we don't know what the cost of ramping up is. We don't know what you're going to end up negotiating. It's deliberately left vague legislatively, but to not know what providers are going to get paid, for hospitals to not know what they're going to get. Are we going to go? I don't know if there's a capital budget feature in the bill, or whether hospitals are paid on a prepaid budget based on previous expenses for the private year. I guess what I'm saying is that it's a delicate balance politically to be vague where you wish to be, because you don't know the answers to those questions, or because you think that they're better left off for future decision making, and or to be specific and then engender the immediate rage of stakeholders that are going to be angry at what you're proposing as being too little. So I don't want to, but on the other hand, I don't want to leave the meeting, which is so phenomenal, at that. I want to remind people that while I'm an economist and a doctor, what Oscar Wilde said about economists, which was that they know the price of everything and the value of nothing.
Yeah, no, that's definitely a problem. And one of the things that hamstrings you if you're trying to do anything in statutory law is that you can't do that kind of detailed stuff. And we would definitely want to have a fiscal note done. But that's about all we can. I mean, if you look at the Social Security Act, it doesn't have any of the details about how CMS promulgated regulations and ended up with all of the fee schedules. So there's something, you're right, you're exactly right. There are some details that you just can't put into statutory law because it doesn't work with the way the structure is set up.
But we have to sell it. The point is
Oh,
that
absolutely. I mean,
and that's the political half of it.
That's where we need, I think that's where we need people like Jerry Friedman to say, here's some examples with math, that will help illustrate how this would work. But yeah. And I, we're talking about actually going back to work with him because his report was from a few years ago. So yeah, and that's one of the things we wanted to do was get, if we get a bill, we want to try to get as detailed a fiscal note as we can, and that's why we wanted to go back and work with Jerry. Yeah.
Thank you for all you're doing.
Yeah, Cindy, we better let you get to your next meeting, and the rest of us can stay on and argue about what you just told us if you want to.
Yeah, if you have follow-up questions for us, just go you can email us, and we'll get back to you.
Thank you.
Thanks so much for having us.
Yeah, okay. Anybody want to argue? I know you would, Warren. I'm unmuting you. You're on the spot.
Oh, I tend to think of it as instructive consideration rather than arguing.
Oh.
But I do have concerns, and would love to have more information on what Gerald Friedman gave them. Gerald admits that his estimates are always optimistic, and whether it's the federal government or the states, they're probably not going to rely on Gerald Friedman. They're going to insist on a fiduciary study by someone who is looking at the low end of the curve instead of the high end of the possibilities. And I don't know that would be true, actually, though. In an initiative petition, But certainly anything that the legislature does is going to require a separate study. I think that was the only argument that I had with, and she felt like that was a waste of time to redo Gerald Friedman. But I think it's inevitable of a legislature or if Congress is going to do something, the Congressional Budget Office is going to have to do a report. They're not going to rely on Gerald Friedman or Robert Poland.
Oh, very good.
Thanks. That's all.
That's a good point. Let's see, I want to hear, how about Walter? You have a comment? Walter Sal or April? I talked with you the other day. Walter just unmuted. Go ahead.
I support much of what Chuck said about political power is essential for us to, achieve those goals. So I'm very happy that you guys are having these seminars, although it's earlier on the West Coast and late for us on the East Coast.
That's right. It's what, 9, almost 10 o'clock for you. We didn't hear from, oh yeah, David.
I'd just like to say that PNHP National is responding to what's going on across the country with a major revision of the mission statement, that the first couple sentences, reaffirm that we're a national single payer organization for education and blah, blah, blah. But then it goes on to say that we understand that we need to work with all these other organizations that are working on social justice issues, and we're going to commit ourselves to that, it's really a wonderful statement, and I think the board will finally vote on it and then get it released in 2 or 3 days. So look for that.
Good. Last night I joined a campaign called Recover Our Vote that was started by Andrea Miller. She's the head of it. The more I called, the more I realized that, and these are targeted to the 6 deep South states, and specifically to Black voters who are off the rolls or haven't voted. And as I made those calls, I realized I need these people as much as they need whatever we're going to do for healthcare. I'm feeling power from doing this. It's one of the most important things I think we can do now between now and the election is bring out voters that are kind of sitting. How about April? You want to tell your story?
No, I think I just feel like I'm still trying to understand all of this, like how this there's the details that just seem so daunting to get to where everyone's trying to get to. So
you want to do a quick summary of what's happened in your family?
Well, yeah, so I have a 26-year-old who's getting ready to be kicked off of my health insurance, and she can't afford health insurance. And of course, her and her roommate were working minimum wage jobs and couldn't afford to not go to work. And now, as of August 10th, her roommate had passed away from COVID. And all because they can't afford healthcare. She could not go to the ER, or she could have, but she didn't want to be bankrupt. And she didn't want to lose her job. And so instead, she lost her life. But so figuring this out is a big deal for a lot, for everyone losing their job, losing their health care, not being able to get health care. But I don't understand the details. I mean, on this call, I'm not understanding how this is different from Cascade Healthcare, how this is going to work, what the work group is. I have a lot of gaps to fill in to try and figure this out, I feel like.
We'll help. We'll keep in communication and try to explain what we're after and make it more sense. Okay. You didn't mention that your daughter gave her roommate CPR at the last. And
yeah.
I'm
It was-
hoping that she can tell that story someday,
Yeah,
or that somebody can.
yeah. But
Hey,
anyway,
this is Sean. I just want to say I'm so sorry about your daughter's situation and her roommate dying of COVID. It's just, it's tragic. It's just another example of how us young people are getting screwed over and over again. And it just sucks. And it just like, I can't imagine as a parent, looking at your kids and like doing the mental, math about, this is where I was at their age and this is where they are at the same age, and just knowing that they're just not going to have as good a life as their parents did. And I think this issue, as among so many others, will stop that trajectory of not having that said good life. I just can't accept that, that me and my other millennials and Zoomers are doomed to, not having a full life. And I think it's, this is another group of organizing that we should be coalescing with and activating. And again, I'm just so sorry.
and that's a tough thing too, because trying to get my daughter and her friends to feel like the system cares about them in any way, shape, or form to make them want to engage, it's not happening. Like, they are so disengaged from anything political because the process is confusing, the process is hard, understanding all of this is difficult, and getting them to want to engage is, I don't even know how that, I mean, I know you're obviously engaged, but most of the young people I know, they're not. They feel like the system is not for them. They want nothing to do with it.
Well, the system isn't for them. And they're right. And they're right not to trust in government. That government hasn't done mostly anything for them or their parents or their grandparents for a very long time. And the challenge is to show them that, hey, there is a fight. This is how we win it. And it involves you and, all your peers.
Which means Instagram.
Well, it could be Instagram. I like to think one-on-one conversations are the best trick. But, organizing. Yeah, continue.
I was just gonna say, I do think it's relational. I don't think Facebook or Instagram or TikTok or any of those things is doing anything for them. They're not engaging on a relational level, but they do have these small groups, it seems, because everybody craves that. And so it does seem that there are these small relational groups that are outside of social media that they're finding, and it's trying to figure out how to tap into that, I think. But
Any comment from Holly or Courtney? The only ones who haven't spoken. Holly's coming on. Can't quite hear you, Holly. I guess we can't hear you. How about Courtney?
Well, I'm up here in Washington. I'm part of Whole Washington, and so thank you for all of this. This has been great. I don't have anything else to add. Just wanted to say
Except
hi.
you sound younger than some of us, so we're very glad that you're here.
Well, I'm in the gap of every option. So even Bernie's option, I'm like the last covered, but it's the shortest gap of 4 years. So I'm really a fan of Whole Washington because that would be even quicker, hypothetically. I'm 43. I have a 10-year-old, or I'm sorry, she just turned 12. I'm looking. I'm looking after her and myself, and an activist working on multiple things, and I don't have health care, and I won't, and I will be the last person to get health care.
Oh, okay. Okay, you fired us up. Oh, Thomas?
Thank you.
Yeah. Thanks to April and you for sharing. Again, like, my heart goes out to you. The only other thing I wanted to say was that what we're working on in the narrowest sense is narrow. Chuck's pointed that out, but even within the medical context, it's narrow, because what we also don't have is a superb, everybody-oriented public health system. The epidemic, when people get sick, hits each as an individual, but most decent and socially conscious countries also have a commitment to community, and that looks like a public health system in this sense. Well, while I 105% support, one payer states' attempts to get individual personal health care coverage for everyone, that doesn't yet go to answer the bigger question of what do we do to get a government and social system that is sufficiently thoughtful, scientific, data-based, caring, and prepared to tackle things like a pandemic in ways that we clearly, obviously haven't seen, Trump and our federal government tackling. It's a separate but co-equal topic, because the truth is that, this virus being what it is, and especially at the beginning, if you ended up getting sick with it, there really wasn't that much that even very good personal care could do. When you got sick enough to be able to not be able to breathe, you had a 50% chance of dying. And that shouldn't be the question, how to get the best ICUs and the best respirators. Yes, obviously, for everybody in this country. But the real question was how to have had a country with enough social consciousness and decent working information and agreement that all of our care is important to my care, so that we could have prevented 100,000 plus deaths.
Right.
I got to go, but just want to thank everybody who participated. I love hearing what people have to say. Thank you.
Thank you, Warren.
Thanks,
Well,
Warren.
I think you gave us a good benediction, Tom. So I guess
I was going to say I got to go too, and I thank so much for the opportunity to meet all of you online.
Yeah. Thanks.
Stay well, everybody.
All right.